We evaluated the non-invasive breakup time, lipid layer thickness, tear meniscus height, the questionnaire, the ocular surface disease index, the inflammation test with the inflammatory test, the mammography before therapy and at each follow-up visit. This is a table that shows the results obtained with the first 6 patients treated. But increasing the number of patients, we had the same results that have been maintained over time. In summary, we found an improvement of symptoms, an increase in the thickness of the lipid layer and tear meniscus, an improvement in the values of NIBUT, and a decrease in inflammation. Over time, we have also found an improvement in the morphology of the meibomian glands associated with their better functionality. In conclusion, also with this technology, it is important to inform patients about the results that can be obtained and their timing. In fact, sometimes the improvements begin 1 or 2 months after the end of the treatment, but the improvements are significant, continue for a few months, and then stabilize after 6-7 months. We had no side effects other than some redness for a few hours after the session, and the patient selection is less important than using other treatments. Sometimes in my clinical practice, I use this technology in combination with other to strengthen and accelerate results that are, however, very good and promising for the future. I recommend only in some selected cases a simultaneous approach with medicines or other devices to shorten the time necessary for the reduction of symptoms. I thank you for attention.
Thank you very much, Dr. Luca, for this very nice and excellent presentation. Now we will have, there is many questions, I think, in mind of our panelists here and speakers. Yes.
I would like to ask Dr. Lucas, very interesting, but it would be nice if you can show us photos of pre-treatment and after treatment, like just to give us idea how clinically it would improve.
Yeah, I have also, do you have any photos? Yes, I have photos, but photos you mean mammography, because you know that I have many data after the treatment, of course. Like I show you the NIBUT values, I show you the lipid layer thickness values. These have no photos, of course, but I have the data. And as regards the mammography, the meibomian glands, yes, I have some photos that represent the morphology of the glands after QMR, after some months from the treatment. You will find that the better shape of the glands that are less dilated or with a better shape than before the treatment.
But you can also give you have in your analysis the quantitative analysis of tear breakup time, for example.
Yeah.
You can. I mean, it sounds very interesting, but also it would be interesting to see these objective measurements, but also to see how clinically it looks in the eye, because we know in the dry eye patients, they will have certain appearance in their eye, redness, some secretion on the red margin. So if you can show us the clinical improvement, also not only numbers, would be more convincing even for us, for the patients.
Yeah, I understand. I understand what you mean, but I can say that the results and the improvements, like I told you, are not immediate and sometimes require some time.
Yes, even after 6 months is fine.
Yeah, but yes, at the beginning, especially at the beginning, if you consider the redness or if you consider the inflammation, I suggest to combine also a medical approach, a pharmacological approach, in order to shorten the improvement of the symptoms, like I said. So I think that yes, patients have demonstrated that they have good results, because also the questionnaire have better results after the QMR treatment. And yes, the clinical point of view, the clinical what do you say, the cornea, the conjunctiva are really better after the treatment. Not immediately, sometimes, as I told you, it takes time, but then I can say that yes, the images and of course the anatomy of our patients are better than before. And
for how long, Dr. Luca, you are using? For how long you are using this technology?
For
now?
2 years and a half.
2 years. Where is it available? Anyone of our here panelists, they are having, or they are exposed to this technology? Anyone of our Dr. Quraishi, if you have exposed to this one? No.
We have actually in our center the IPL. I don't know, Dr. Loka, about the intense pulse light therapy. Do you have an experience with it? And if you can compare that, we have it almost 3-4 years from now, and we're trying to do a scientific study about it, and we saw some promising results, but I don't have any idea about the quantum response.
It is the same. Is it the same technology, Dr. Khaled? Is it the same?
It's different. I think it's
different.
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 Okay.
IPL is completely different because
a laser based, right?
Light, pulsed light.
Pulse light, intense pulse light.
Pulse light.
Yeah. I have experience with intense pulse light because I've been using it since probably 5 or 6 years ago. So a lot of experience. And what I can say is that the principle, mechanism of is completely different, because the IPL stimulates the meibomian glands and not the lacrimal glands, because the IPL acts on the parasympathetic nerve, and so this way stimulates the meibomian glands to work better. The QMR, the Rexonai, acts with a regenerating effect on cells and tissue, so it's completely different. Sometimes in case of mixed dry eye, I use both in combination. I use QMR plus IPL because I want to have better shape of my glands, and not only the meibomian glands, but also the lacrimal gland in case of hyposecretive eye, and I want at the same time also stimulate the meibomian glands using the IPL. In very difficult cases, in very strong cases, I recommend to use both techniques because they may have a synergy and they not one against the other, and the principle of action are completely different. Okay.
I'm very thankful for your knowledge about the quantum, because really we have problem with the dry eye, even the severe one or that one not responding very much to the conventional therapies. Hopefully this technology will add to us. Thank you.
Question,
Dr. Quraishi, please. Dr. Quraishi, Osama or Quraishi.
Dr. Luca, just because I understand from you, is more direct.
Quraishi, we cannot hear you. Your voice is mute.
No, have you done any trial to see effect in one eye compared with the other eye? Because if it's mainly direct to one eye, so you could treat one eye and see the other one as control.
Good question. Unfortunately, I couldn't because I'm in a private practice, so it's very difficult for me to treat only one eye and not the other in my patients. So I did not this kind of study. So anytime when I had to treat a patient, I had to treat both eyes. But what I can say is that the control patient, I mean patient that didn't undergo this kind of therapy and only were treated by standard therapies, didn't have the same results like in the QMR group, especially of hyposecretive dry eye. that are really difficult patients. I mean, patients with a lot of steroids, a lot of cyclosporine. In these cases, particular cases, I had very good results in doing the QMR because I had an improvement in the tear meniscus height. That means that QMR works on the lacrimal gland.
But anyone did the study like this, because really very important to, if you had the easy to have a control with the other eye, that will prove that the treatment is good. But it's easy to do that. I think it's even few patients will tell you much better than different people. You know what I mean? Yeah,
I think you're right, but also I think that is not easy because the Googles that the device is you saw in the image is done by Googles and of course a platform where you can change some parameters, but Googles with some electrodes inside where the current pass through are for both eyes simultaneously. So I think that we should ask the company to provide only a single eye mask in order to do this kind of study.
Or you could do a barrier, and that give you a better
yes,
control.
You can do a barrier.
And that give you to the patient. Right. You can have ask the patient as random, and then you put a barrier in one eye, and that will give you a very good result and more convincing to us, really, for everyone, that if it's the same patient have different parameter.
All right.
Thank you very much. Do you hear me?
Yeah. Can you, Dr. Quraishi, please go ahead.
Okay, thank you very much. Very nice lecture, and I think it would be nice technology. I had heard about this technology before, but I didn't use that because I'm sure that it has been released recently, and not many people have that. I myself have experience with IPL, and I had the same question that you already answered. So comparing IPL with this technology, and as you said, this may be a better technology substitute for, or maybe complementary to IPL. But as you said, the question, how many sessions you do that? This is the first question. And second question is, do you have an experience with other conditions such as cicatricial cases, Stevens-Johnson syndrome, or mucous membrane pemphigoid with this technology? Have you any experience with those patients?
Okay, first question, how many sessions? The standard protocol is 4 sessions. So 4 sessions, one per week for 4 consecutive weeks. So this is the standard protocol that is recommended. Sometimes I did some more sessions, so also 5 or 6 sessions, but I have no particular experience with syndromes like the ones that you were we are saying. I had some experience with blepharochalasis, and I had some improvement in this kind of particular kind of alteration of the conjunctiva anatomy. And in this case, I had some improvements, but I had no particular experience in case of pemphigoids or other kind of lupus. I have some experience in Sjögren syndrome because I treated some patient with Sjögren syndrome with, I think, good results, not 100% improvement, of course, because you know that these are particular difficult patients, but with some improvements, yes.
Sorry, is there any experience of repeating these sessions? When you can repeat? I mean, if you have, how long when you can?
Usually, if I have to repeat to tell the truth, I have only few patients that asked me to repeat the treatment because, as I told you, the benefits are long-lasting benefits. So I had to repeat the treatment after 1 year or 1.5 years in selected cases. So it's not so common to have to repeat this kind of therapy. It's completely different from IPL, where I suggest to repeat or to enhance with another session after 6-7 months. In this case, it's not required. Sometimes you can do it if the patient starts to complain again, but it's up to you. It's not normal. It's not normal.
Dr. Luca,
How much it cost?
One question, if you don't mind.
So yes, Dr. Safwan.
Dr. Osama, he tried to mention a few things related to how we can differentiate by keeping one eye and doing for the other eye, just to differentiate which patient that will get benefit from this technique, not from the IPL. Now, I have a lot of patients that I'm receiving. They did 1 or 2 or 3 sessions of IPL, and still they have breakup time and stable breakup time less than 10 seconds. Now, the issues is that here is to differentiate between the meibomian dysfunctions and the goblet cell loss. The goblet cell loss that will lead to shortening the breakup time, and the meibomian dysfunction also it will lead to shortening the breakup time. So in your condition, in this technology that you mentioned, how we can select those patients, those that they are eligible for this technique, not the IPL, or they are eligible for both, or they are eligible for the third. It means that the conventional treatment plus the IPL and your technique.
Good question. I can say that first of all, I recommend this treatment in case of hyposecretive dry eye. This is the first, my first group of patients who was a hyposecretive dry eye patient or mixed dry eye patient. So I think that the most of the majority of the results, we may have the results in case of hyposecretive dry eye patients, because as I told you, this technique acts on the lacrimal glands also, and not only on the meibomian glands. Second, I think that in case of meibomian gland dysfunction, you have to share patient with obstructive meibomian gland dysfunction from functional meibomian gland dysfunction, because in case of obstructive meibomian gland dysfunction, I don't recommend QMR, because QMR does not disobstruct the glands, but only acts on the morphology of the glands. So if you have glands that starts to go towards atrophy, or with dilation, or they don't work in a proper way because they produce a very dense meibum. In this case, I can recommend the QMR and also IPL, because I want both. I want to regenerate the cells and tissues, and I want also to stimulate my glands. But not
Thank you, Dr. Luca. Thank you, Dr. Safwan. We have 2 questions from attendees. We want to answer this one before we move to the second part of our session today. There is one question. They are saying, did you mean blepharochalesis or conjunctivochalesis?
Conjunctivochalesis. Conjunctival.
Okay, and other question from Dr. I think Dr. Khalid also, he answered this one. There is another question. What about a lipid flow? Lipid flow.
Yes, yeah. I have also lipid flow, and I use lipid flow to disobstruct the glands, the meibomian glands, in case of obstructive meibomian gland dysfunction. So in this case, I think it is effective, and I recommend also lipid flow. Yeah. But
I have a question, Mohammed.
Okay.
With this.
Yeah, just two questions, quick one. Have you done anyone after LASIK surgery, dry eye after LASIK surgery? Does it promote healing and promote dry eye? The second thing is how much it costs the machine.
I did it after LASIK surgery and also after cataract surgery as well. And the cost, I don't know exactly in the Middle East how much may it cost, but in Italy we can rent the device. And so since there are not disposable parts, you can usually I ask the patient 150 euros per session. That means 600 euros for sessions, so the complete treatment.
Okay. Is there any other question from any other colleagues here? Thank you very much, Dr. Loca, for this very interesting about a new machine introduced to the market for treating this kind of disease that we are facing and every day, and with a very high number and percentage of patients we are seeing, especially in our area. If there is any other question, we will find or someone that we can keep it.
Muhammad.
Yes.
Hopefully that the company will provide it to us for a rent, because that will help us in at a moment.
This one you can check, Dr. Safan. I don't know. This one, yeah. I don't know. You can ask Dr. Ala. He will give you the answer about this. Dr. Ala Zawawi. Renting, Safan, you have to buy. You have a lot of money, Safan. Why you are asking for a rent?
In this moment, we don't have. All of us.
Safan.
Anyway, I think Dr. Khalid Al-Arfash, he will buy and then he can rent it for you. These are the only options.
Anyway.
Okay, thank you very much. Thank you, Dr. Loca, and thanks for all our panelists and speakers. Now we will move to the second part of our session today with the second episode of cataract. And we divide this one into 4 parts. We will give the first talk. It will be Incision and Capsular Axis by Dr. Yahya Salahuddin. Dr. Yahya, I think everyone know him very well. He is a professor of ophthalmology, Cairo University, Egypt, consultant cataract, cornea and refractive eye care center, Cairo, Egypt. Dr. Yahya. You are mute. Just unmute yourself, Dr.
Shukran, Dr. Mohammed. Thank you, Dr. Mohammed. I think we will move on. I'm going to speak about very basic, important topic that everyone should really learn and to move on into the surgery as we are planning to do in this course. So I will touch up on the incision, and I just want to tell our colleagues that an incision, when you are making the incision, it should give you an easy access to the anterior chamber. And this means that the shortest route, for example, for myself, I prefer a tempered clear cornea incision. But for any site of an incision, you need an incision that will not obstruct your working. So if you're sitting at 12 o'clock, don't do the incision at 12 o'clock. You don't need to be obstructed to obstruct your handpiece. So mechanically, you would easily work inside the anterior chamber. It should not be too short or too long. Too short, as we in the session of complication, we will touch up on this. And it should be self-sealing post-operatively. This is the way you think how you construct the incision. And paracentesis should be placed properly in relation to the main incision to help you, again, mechanically to work at ease and simple. You can see here, I work almost all my cases under topical anesthesia. It doesn't make a difference. The main thing I want to show here is that if you do an incision, you have to fix the eye. I'm fixing the eye here with the super blade or the MVR, just because I'm working under topical anesthesia. You do a biplanar or triplanar incision, and you can see that where the arrow there in the first photo, I do not by the tip of the keratome, the scratch. I do it just behind the tip and not by the whole side of the keratome. Then you have to measurely and under vision see where you penetrate the descemet membrane. The idea to create the length that you want, the ideal self-sealing wound should be nearest to square shape. If you use a larger keratome, this is a 2.2, but you might use, in some places, you can use 2.4 or 2.8 according to your setting. Then you are getting closer to a rectangular shape. The most important thing, where you start your incision, never start it too corneal and don't make it too short, and you can control the length of the incision by dissecting into the cornea until you pierce the anterior chamber where you want. The ideal landmark for you to see where to pierce is the reflect. You can see the reflection of the light of the microscope on the surface of the keratome, indicating that you are parallel to the iris, and this is the plane that you should go into the anterior chamber. Then the placement of the paracentesis. Just this is a quick video just to show you how under topical that instead of the super blade here, you can use a fixation forceps, but always penetrate the eye with a forceps that counter traction to pierce the anterior chamber in a controlled way. So my give away pearls, you have to think what you need from the incision, and this will lead you how to construct it and where to place it. Let's move to the more important and very valuable step that everyone should master, which is the Capsular Axis. It's a crucial step. You should not, I advise my residents always to perfect Capsular Axis to move to the next step, and it should be reproducible. And to make it reproducible, you should know rules. And we can do the Capsular Axis either or a needle or a forceps, and it's better that you learn both. And the rules I said are essentially 4 golden rules. 1 is work in a deep anterior chamber. 2 is to hold near the tearing edge. 3 is to move systematically every 2 clock hours. 4 is to bring the flap, the enlarging flap, to the center to get it away. And for each rule, there is a reason. And you have to watch all the rules all through the steps so as to have it reproducible. And I add a 5th rule. I encourage everybody to work under high magnification, because under high magnification, you can really see what is happening, and what you need to learn is to shorten the learning curve. Shortening the learning curve always depends on rules and knowing where you are good and where you are bad, so you can reproduce the technique and improve each time you work in a much, much shorter period. This is a video. I will just compile almost all types of the rules and all types of cataract where we do Capsular Axis, how to make it easy. The Capsular Axis, as I already started to mention, is very important, and it has made a great shift in the safety of the technique of phacoemulsification. It is essential and very important to do proper hydrosection is to have proper Capsular Axis. It is important to be able to do phacoemulsification inside the bag, to do irrigation aspiration safely, and to center the intraocular lens in the bag. The rules that we should follow, we should have a deep anterior chamber. In this way, we neutralize the pressure of the vitreous pushing forward. So in this way, it's our hand, the Capsular Axis forceps or needle is the only controlling force. And then we move it in each 2 clock hours to be systematic and repeatable, to hold near the tearing edge, not at the tearing edge to avoid extension to the periphery. And we bring the flap to the center to avoid the flap making a track to the equator extending. And under the incision, it's usually the typical place for beginners where they have an extended capsule, Capsular Axis. So it is clear rules. Either you are beginner or not, you can follow. We can puncture the anterior capsule with a cystotome, with a forceps, whatever you can puncture it. Now we will see the rules, filling the anterior chamber with viscoelastic, really deep anterior chamber, neutralizing the vitreous pressure. Magnification, you can see the value of magnification because you really can see exactly what you are doing, holding near the tearing edge. moving every 2 clock hours, bringing the flap to the center. So every point, everything is under control. If you lose some viscoelastic, just stop, inject viscoelastic. This is a very reproducible way. If you are using the needle, I will show you a trick. You do the first bend at the tip, don't make it too short, not too long. Then the second bend at the shaft. And the main trick is to do a second bend off axis. And this will completely eliminate the problem of using the needle when you are near or under the incision. Exactly, it's the same rules you apply, whether you're using a capsular axis forceps or you're using the needle. Deep anterior chamber, moving every 2 clock hours, bringing the flap to the center, and catching the axis near the tearing edge. Very reproducible. Using whatever tool. Filling the anterior chamber, you can see. Holding near the tearing edge, here, near the tearing edge, not at the tearing edge. I stopped here, injected viscoelastic because I broke the first rule, which is deep anterior chamber. If you have the rules in your mind, immediately you can correct what is wrong. It's almost impossible to fail in capsular axis if you follow the rules. Even if you are very experienced, you can have a problem if you break the rules. In any type of cataract, you can do the same. Very controlled, very reproducible. Always make the first incision near the center, not in the periphery. See under the wound, you can regrasp easily because you are doing it in a very systematic way. This is a pediatric cataract. And even in congenital cataract, where the capsule is very elastic, you just change the way you pull. The capsule is very elastic. It tends to extend. So you do your pull to the center as if it is a radius. So you will always get the circular opening that you need. In pseudo exfoliation, make sure you don't go do a big capsular axis to reach the zonules, because these patients might have zonulisis and you'll need the capsule. In hard cataracts, black cataracts, the same rules. Whether you need to stain or not, you can stain, or if you can see, don't stain. But again, with magnification, you can see here. And you follow the rule. Only if the ideal axis is 5 to 5.5, you try to make it a bit larger in very hard cataracts. Intumescent cataract carries a different addition. You want to change it into a normal case. In intumescent cataract, the capsule is tense because the pressure inside the bag is high, and the capsule would tend to extend, and you need to have I don't know why it's not working, the movie now, but you need to stain it, and to overcome the problem of high pressure inside it, I make the first incision curved, so it will, even if it extends, it will go in the way I want it, and then you decompress it by aspirating the contents to convert a difficult case into a regular case. And as you move, you can check if there is any break of the rule. You can stop, inject viscoelastic, and re-aspirate to deflate the bag. It's always you are observing the rules and seeing what is making this case difficult, so you can immediately stop, correct the faulty rule, and continue in a very, very controlled, reproducible way. And this is extremely important in capsular axis. you need to be reproducible, and this will decrease the learning curve. Here, even in a small pupil, this is pharmacologically dilated, even in a small pupil, you can manage because you already see well, you understand the mechanics of the capsule, so you can interpolate and use the small iris to help you direct a little bit larger rexus continuous behind the iris. You can use two hands technique by pulling the iris and seeing where is your edge, reminding you to follow the rules. Here, one of the important signs to notice, this fold signs is an indication that this capsule or this lens is subluxated. So you have, if you did not notice preoperatively, you have to be careful and change your technique. So the capsular axis is extremely important. It is extremely reproducible. And as you can see, I just will revise it in a very fast way that you can see filling the anterior chamber. So as you know how it is filled, this is in a slow motion just to tell you and to show you, following the rule, how it can make it very reproducible. And you can see the magnification really makes you understand what is happening, understand how the capsule behaves, and understand and see where is the capsule extending, and seeing this in the correct time. I will touch up very fast because we did not mention it in the program. Just the capsular axis is important in hydrodissection, and the rule for hydrodissection, as you can see, you have to see a wave passing behind the capsule, the nucleus, and let it go from the other side. This is a sure sign of hydrodissection. I will just make it in a slow motion, as it was in a slow motion, just to add up. In conclusion, there are 3 basic steps for any surgeon starting phacoemulsification. He should master before jumping into the rest of the technique, because this will make his technique reproducible, much safer. A continuous axis gives you the luxury to learn in a safe way. So these 3 basic important steps, how to make an incision, capsular axis, hydrodissection, should be perfected before moving on in phacoemulsification. Thank you for your attention.
Thank you very much, Dr. Yahya. Very nice and excellent. Even though there is many questions about the, in my opinion at least, you go very fast about the incision. Incision also is, I think, a very important when you start.
It is very important, but the time is impossible to cover everything in detail. So I expanded in the capsular axis because it is very important, and maybe in another session we can give more details. I gave the highlights of the incision.
Okay. Is there any question from? Can you stop share, please, Dr. Yahya, please?
Dr. Yahya, what's your advice about the sizing? Well, how people do, because people tend to go smaller and smaller with time. So what's your best way to help people to decide the optimum size of capsular axis? I have a catalyst, which is very good. Just you can.
Yeah, away from femto. Of course, there are special capsular axis with the sizing where you can size, but generally, I think you get it by experience, because by time you learn, you know that the optic of the eye, most of IL we use now 6 millimeters. So you learn to do your intention to be 5 to 5.5, which is always less than the size of the optic of the optic of the IOL. So this is the way you learn it by experience. Otherwise, there are markers on the cornea you can use. I've never used it. The capsular axis, which is marked, you can use. I didn't use it, but all these are useful tools, of course.
Yeah, we had the Callisto. I mean, it's really useful, by the way. I tend to undersize mine sometimes. So.
I have one question for Dr. Yahya. Thank you. You covered very well the very important step in the fundamentals of phacoemulsification. And regarding the size of the rixus, I might recommend at the beginning to go larger size, because many of your videos I have seen a smaller size. In the beginning, you make the phycomulsification more difficult if you have a size of 5.5 or 5. I think 5.75 or 5.5 at least will be better for the resident to start with the larger little bit rexus to manipulate very well. This is one question. This is one comment, actually. Let me finish. Other thing is the type of Helon. I didn't mention about it, but I think it's wise to choose a really cohesive type of Helon that thick. 1% is not good at all. 2% is equal, but even at the beginning, 3% will be very good to help to form the anterior chamber very well and do the rexus nicely at the beginning. So 3% of cohesive Helon might be very good at the beginning. So I mean, this.
Okay, I can.
More last comment about the incision. If you need to do it under topical anesthesia, I think the tone of the muscle tone will be enough not to have your support for the incision. I mean, if you have an experience, but definitely if you have difficulty with that, you might use the support of.
I have experience, but I don't think anytime you go into the eye, you should leave it even to the muscle tone, because he can move away. You can ask the patient to look away, and you always, and particularly talking to less experienced doctors, there are rules that should be followed. The rule.
I do all of my cases topical anesthesia. I don't have any support, and most of the cases.
Yes, but you are an experienced surgeon. We are talking.
If you don't mind, just one comment.
We have to have rules.
Yeah,
1 minute, Dr. Safar.
I do agree with Dr. Yahya that the issues is that if you don't have support, and then you will go in and there is any difficulties, you know that all our blades is not 100% perfect. So sometimes you need more pressure, so you will go in and you will hit the capsule, and if you don't have support. So I do agree with Dr. Yahya. We need, especially if we are
talking, if you allow me, okay. It's not a big issue to be supported.
No, let me, Dr. Muhammad, it's very important issue is the viscoelastic.
Yes.
Of course, it is ideal to have cohesive, like Helon, for example. But again, we are talking to people from all over the Arab nation or other countries. And the price and availability of what you have is very important. What I want to convey is any type of viscoelastic. This is why I did not touch up on this. Of course, if we have the luxury, we give the patient, the residents, the Helon, for example, and it is nicer. Why it is nicer? Because you don't break rule number one, you don't lose it easily. And this is correct, it's very useful. But again, for those people who are not, they don't have available other types, then except methylcellulose, even in lower concentration, they will learn by following the rules that if after two movements, they lost some viscoelastic, they lost the anterior chamber, they stop, inject again viscoelastic. And by time, they will learn not to depress the edge of the wound, losing this viscoelastic. So your comment is correct, 100%, but still for whoever who's listening to us, you can do an excellent reproducible capsular axis even with methylcellulose 1%. And for the size of the rexus, I agree with you. And also the main worry, as you mentioned, for beginners is to have small rexus, because for beginners, they want to make it continuous, but they're not really looking how big it is. So they will do it very small. And this is really much more difficult. So I agree with you.
Dr. Yahya.
Thank you very much, because already, Dr. Yahya, you take more than 22 minutes or more than that. So thank you very much. It was very nice. We need a lot of time to talk about each subject, I know. Just now we'll do only a highlighting about to highlight and give the tips and tricks about each topic that we are going to talk about. Maybe later on we will find some times to discuss one topic's more details. We want now to Dr. Sharif, he want to comment.
A very small tip. I like Dr. Khalid's comment, and thank you for the excellent presentation. If you are going to use methyl cellulose, I advise you use a needle tip using the Capsule Access, as it does not disrupt the wound and allow the viscoelastic to come out. But if you are a regular user of the forceps, then I recommend Healon, as it because the wound is open with the forceps, so Healon will not come out. This is just a small addition.
Thank you, Dr. Sharif. Now we will move to Dr. Ala. Dr. Ala Zawawi, he will give a talk about divide and conquer techniques. And Dr. Ala is a professor of ophthalmology in Alexandria University, Egypt.
Good evening, everybody. Hello, and welcome from Alexandria, Egypt. Today, our talk will be about basic phacoemulsification, and I will speak about nucleus management. Nucleus management actually is a very important step in phacosurgery. Actually, we have so many techniques. It started by actually the divide and conquer technique that I will speak about today, and then it turned into stop and shop technique by Douglas Koch, and then Nagahara introduced the shopping technique, and it has been divided into horizontal shopping and vertical shopping. These are all techniques in order to manage the nucleus, in order to be able to get smaller pieces to get them out. My talk today will be about the divide and conquer. Actually, myself, I started phaco in maybe 1999. I started by chopping, direct chopping, and then I changed it rapidly, very rapidly, to stop and chop technique. And I used to do it for almost 10 years. And then since 11 years now, I am doing divide and conquer technique, and I am very happy with this technique. To start with, this is a rapid cortical cleavage hydro dissection, and that's what Dr. Yahya has told us, that it is a very important step. And don't start your phaco except after rotating the nucleus. This is the usual divide and conquer technique. I am starting by removing some of the epinucleus from above the lens, and then doing the trench. Here, the trench, it needs an experience for how long and for how deep. How long, you have to go a little bit toward the periphery, but you have to see where is your tip. And how deep, it must be deep enough in order to do the crack. Deep enough, this may be the diameter of the phaco tip, and you are doing it by the changing color that you are seeing while doing your trench. And then after, you have to be very careful in be sure that the trench is very well done and the division is complete, and then it will be easy. The first, of course, the first quadrant is the most important and most difficult one, but thereafter there will be easy removal of all the quadrant. If you have a good machine with stability of the anterior chamber, everything will be okay. And if you have done a good cortical cleavage hydro section, here you are finding that there is no cortex because of the good cortical cleavage hydro section. A point to remember that the anatomy of the lens. This anatomy, that means that in the center, you have deeper or thicker part, and in the periphery, it is less thick. That's why your trench must be deeper in the center, and when you are moving toward the periphery, you have to raise your hand a little bit up. Always remember, while you are doing your division, this anatomy of the lens. Let's see another case with a slightly smaller, narrower pupil. Yes, after the capsular axis, I'm doing the hydro dissection and then rotating the lens, as you are seeing that. Always rotate the lens and don't start your phaco without actually seeing the lens rotating very well. Here, another time, the divide and conquer technique, go deep, but you have to see the tip of your phaco machine, rotate completely in order to have half of the lens here till the edge under, you are in another plane under the edge of the pupil, and then assuring the division. Yes, it started division. I am leaving it just one attached to the other. I am doing the other cross and along division. Yes, the red reflex has been seen, and completing here the red reflex, and the fourth crack has been done. And be sure that you are separating each quadrant very well before starting. And this is very important in narrow pupils. Once this has been done, you can work a little bit in the pupillary plane, just above in such narrow pupil, and it will be in the safe area, away from the endothelium and also away from the posterior capsule. And if you have a good machine, again, you will find that the fluidics are very well, and you are doing it very rapidly, and finally you get the 4 quadrants out so easily. Can it be done in white cataract? Yes, of course. And the trick here, if you can get a larger rhexis, as we have discussed in the previous issue, it will be better. And you have to go deep, and you have to go to the periphery in order to reach the edge of the lens. But always remember that the thickness in the middle is much more than the thickness in the periphery. And you have to crack, and the idea here is to go deep. Once it has been cracked, you can go to the other edges and to complete the 4 quadrants. Here it's hardness +3, for example. It is not soft at all. And you can deepen and deepen your trench in order to achieve such technique. Actually, I am doing it, and it's much easier when there is some hardness. This is somewhat harder than the usual, but when there is some hardness, this technique is very successful. And don't start to get your quadrants except if you have the 4 quadrants really separated one from the other, like here, and you will start getting one by one. Yes, assuring that all the quadrants has been separated from each other, and getting the phaco tip is down, bevel down now. I am away from the posterior capsule and away also from the endothelium, working at just the pupillary level, controlling the pieces. And again, you can finish all the 4 quadrants. The most important is to get really a good division of all the parts. Can it work in soft cataract? Yes, this is a case of soft cataract, and this is Centurion with the balanced tip, and you can also do the division, although division is difficult in such soft cataract cases. And sometimes division is not complete in such cases, but at least it gives me a certain space in order that the quadrants will be able to move. Here, as you are seeing, that it is not easy to do the division. Why? Because the cataract is soft actually. But still, I am doing the trench, even though there is no complete division, but at least I have the space in order that each quadrant, one I will do the phaco 2, I will be able to pull each quadrant toward the center. That's why it gives me some advantage in beginning and doing, but although here there is no actual division of all the quadrants, but at least there is a space that you can move here. The rhexis is okay, and the quadrants has been moved to the center, and you can achieve your phaco completely. This in soft cataract cases, it will be easy, of course, because there is no power used actually. This is using the inguinity, and you can, if you have 3D, this is also the balanced tip of the Centurion, and you can, if you are watching the inguinity with the 3D, you can know which depths you reach during your phaco in doing the trench. Here you can go deep in the center and more shallow in the periphery, and then doing your division. And once you are seeing the red reflex, go to the rest Reproducibility, as Dr. Yahya Salah has told us, is the key factor. I like this word quite a lot. You have your technique to be reproducible. And actually, I am trying to have a reproducible technique. Here, I'm doing the division and completing each quadrant separation, and this will assure the easy removal of each quadrant. Maybe the last video will be, it can be for very hard cataract. Yes, it can. The key here is to go very deep. Actually, you do the trench, be patient, go deeper and deeper and deeper. Yes, it will take time from you, but it's okay. Add viscoelastic, go back again, and then going deeper and deeper till you achieve the proper level in order to do the crack. The tissues may be stuck to each other from behind, but the key factor or the most important key point here is to go deep and deep till this posterior plate will become thin, and then you are able to crack. Knowing divide and conquer technique does not hamper you from knowing other techniques, because not all cases will be successful with such technique, and you have to learn other techniques also, like stop and chop, direct chopping, vertical chopping, horizontal chopping, or ship and flip techniques, because you must know more than one technique. But I mean that divide and conquer in my hand is a reproducible technique, and I can use it in most of my cases successfully, alhamdulillah, and with a rate of complication that is within the normal limit. Thank you very much.
Thank you very much, Dr. Ala. Very nice and excellent and comprehensive talks. Just we want to concentrate in our comments, and I will leave only the comments for the panelists and questions about the tips, because the most important here, we need to know when you are going to do a divide and conquer. Okay, this is the technique, but you want to crack the nucleus. We need where to put the two instruments, yes, so that can be easily done. I think this is the most important. We want to concentrate about it. I don't know if there is any comment. We are having Dr. Muhammad Qureshi. Let's start with him to start. Yes, Dr. Muhammad.
Thank you very much for a nice presentation. I think you have to customize your technique based on the patient and the nucleus that you have. I routinely do chopping technique, but for example, as what is called chopping.
I have difficulty to hear you, Dr. Muhammad.
Yes. Yes, me too.
Can you hear me now?
Yes. Okay, but there is a voice okay, please go ahead.
I'm audible now.
Okay, it's good now.
I think we have to customize our technique based on the type of the nucleus of the patient that has, or the condition of the eye. My routine technique is chop technique, but I use sometimes divider and conquer. But for example, if you have a soft nucleus, it is difficult to do chopping or to do divide and conquer. So for very soft nuclei, I use chip and flip technique. And for usual cases, I usually do quick chop technique. And the challenging cases are those who have Brunesen cataract. They are very difficult to do even chop. If you are going to use only chopping technique in these cases, you have to use a lot of energy for this, because you have to go deep, and if it is very, very leathery case, you have to use a lot of energy. So I think only chopping is not suitable for very, very hard nuclei like Brunesen cataract. So in these cases, I do a combination of, I start with divide and conquer and then do partial chopping. You cannot do complete chopping in these cases because the nucleus is leathery, especially in the posterior part. You cannot do complete chopping. So I have a special technique. I call this disassembling the nucleus. So I start with some degree of divide and conquer, and then I do partial chopping at the periphery and also do some chipping. And I have technique, I called it back chopping. I take the nucleus in the mid-periphery and flip it, and with my chopper go into the back and rotate that, flip that, and it is separated from the back side, because this is the difficult part, is the back side. Unfortunately, I couldn't publish this technique, but maybe sometime I will publish that. It works very well for very hard nuclei. So this is called back chopping technique. And there is also some devices that, as you know, for example, Zeiss has a my loop technique. You can use that for those cases. These are my viewpoints.
Thank you, Dr. Muhammad Quraish, for this. But maybe in the future, we need to see in a video your techniques, because sometimes description, it is very not easy to understand it easily. Okay, can we have Usama? Yeah, Dr. Usama, Dr. Yahya, then Dr. Sharif, sorry, after that. Dr. Usama, you are with us?
Yes.
Is there any comment or questions?
I think Dr. Sharif wants to speak, so I'll leave Dr. Sharif now.
Okay, Dr. Sharif. I will not come back to you, Dr. Usama. Okay, Dr. Sharif, he gives you his place.
Dr. Muhammad.
He's a very nice gentleman. Thank you, thank you. I would like to ask Dr. Ala to tell us about certain tips that are good for the starting surgeons, like, for example, where to extend with the phaco tip when I'm doing my divide and conquer, and how useful is the hydrodelineation in delineating the nuclear edge so as not to go past through it. This is number one. And also I would like him to emphasize about the depth, because sometimes when you try to go a little bit deeper, you can go past the nucleus and injure the posterior capsule. So how to prevent this? These are very important tips that I would like Dr. Ala to tell us how we can avoid such complications as new surgeons or new residents.
Thank you, Sharif. Yes, they are very important 2 points. Actually, to go till where to go to the periphery, actually, I am recommending always to see the tip. And when you are, your tip will be under the level of the rexus. Start in the middle, you are getting in the middle of the lens, and then in the periphery, you will be at a level under the iris, under the edge of the rexus. But actually, don't go too far. You have to see what you are doing. And this is the main problem in actually the narrow pupil. Because always, as anterior segment surgeon or any ophthalmic surgeon, we would like to see what we are doing. Don't go blindly at all. Regarding the depth is really a big issue. Actually, it's the change of color. The change of color that will tell you that you are deep enough. And where to separate, as Dr. Muhammad Al-Amri has told us, yes, it's very important to be deep in the trench. Don't be superficial, otherwise it will break like that, but the posterior part will be adherent to each other. You have to be deep in order that to separate the 2 parts. If they are not separating, go deeper and deeper. And the problem that how far deep, this is an experience. This is an experience in order not to break the posterior capsule. And always, I am erring a little bit not to go so deep, because it will be a major complication if you break the posterior capsule at this level or at this step of the operation itself.
Dr. Ala,
and what is your recommended?
Simple comment,
Dr. Ala, can I, 1 minute, please, if you allow me.
What is your
Dr. Ala, I think before we are teaching, like when you are doing, divide and conquer, and how long you go deep. Before, the era of now, the new microscope, we say when you start seeing the red reflex more clear, that's then, or 2/3 of the tip of the, that's maybe this is the only the deep you can go safely. I don't know if this point is valid now or.
Yes, it's up till now it's valid, of course. The change of color, yes, of course, it's always valid, Dr. Muhammad. Yes, what you are saying.
That's why that's what we need. To tell about how we. There is another question, Dr. Ala. Sometimes it is very easy even to use a special crackers of the nucleus rather than to use only the tip and the other one. For the beginning, sometimes it's very easy to go in the center and just open it very easily. I don't know if you have any experience or you have seen this.
Akahushi.
Yeah.
Yes, I
Yes,
used
I
it.
don't want to mention the names. Okay. Okay.
No, it's okay. It's
But
well
But
known.
there is some of them. They're not akahushi actually. It is like a forceps itself and not sharp from the down. So yes,
Same.
of course. Yes, there is sharp and there is not sharp. Of course, I use them, but actually I am not finding them very useful too much, at least in my hand. And I am not seeing them among my colleagues also, meaning that actually with the tip and the repositor or the spatula, you can do actually the separation quite efficiently. Personally, I don't use these instruments. And among my colleagues,
One simple. No one noticed, Dr. Ala, what he used in the type of the illumination of the microscope, which is very, very important. What he used is that he is using Zeiss microscope, right, Dr. Ala?
Yes, of course, yes.
So that microscope having the ability to change the illumination from 3 dot to 2 dot to 1 dot. So he used 2 dot if someone noticed, and that gives him the red reflex in a very clear way. I know that Dr. Ala is smiling that because we are both in one wave. So that two dots give the surgeon a very good red reflex. So once the red reflex started, and he was doing it in a very professional way, it's the time to stop and then do the crack and the deep, your hand deep to the edges of the heart is to separate, and that's all.
Yes,
Great, thanks, Dr. Ala. It was a very comprehensive.
Thank you very much.
Dr. Sharif,
I think just to assure everyone hearing us that we are going to talk about all this in details when we are going to talk about a soft cataract, when we are going to talk about hard cataract, then we'll go more deeper and we will give more tips and tricks about how to use this one. Just, I think, a generalized introduction for what we are going to talk about in future. I think it's now the time to move to the next session. It will be by Dr. Sharif, and Dr. Sharif is going to talk about phaco-shop techniques. So the other techniques that Dr. Ala talk about, divide and contour, and Dr. Sharif will talk about phaco-shop technique. It is what, recorded, Dr. Sharif, or what?
I'm trying to share the screen now.
Okay.
Okay.
It is
Do
already
you have the screen?
Yes.
Okay. I'm going to continue the talk about using the chopping technique. And Dr. Ala showed us the divide and conquer, and now I'm going to talk about chopping. And we have to understand exactly the difference between chopping and divide and conquer. I recommend to most residents who are trying to start phaco to start with divide and conquer in order to go through the difficulties and complications that they will see during the divide and conquer. And because I think that chopping is much, much more difficult than divide and conquer. It's quite faster, but it's not safer than divide and conquer. So I recommend for all beginners to start with divide and conquer. And if you are confident with divide and conquer, please continue using divide and conquer, because as Dr. Ala told us, it will go through all types of cataract with ease and safety. It's just a little bit longer, it takes longer in time, and maybe sometimes it utilizes more phaco energy, but in divide and conquer, we use less phaco, less flow rate and less vacuum. So it's a little bit safer than chopping. Chopping has some advantages over divide and conquer other than it being faster. It gives you the ability to divide the nucleus into more than 4 quadrants. In divide and conquer, we can only divide the nucleus into 4 quadrants. However, in chopping, it's like cutting through a pizza. You can cut it 4 parts, 8 parts, whatever number of chopping you want your desire to perform, you can do. So I recommend, because vacuum is very, very important in chopping, that you should start with high parameters. The vacuum should not be less than 400 millimeter mercury. And when you engage the nucleus, you have to engage early in the upper 1/3 towards you, and then apply vacuum and emulsification till the deep is deeply buried within the nucleus and reaches the center. Do not exceed in chopping with your tip the center of the nucleus, because you will go through softer nuclear segments, and then you will lose the vacuum if you go through this. I prefer to use the Neuhan chopper. And as I said before, the denser the nucleus, the more the number of chops performed. This is an example of eating a piece of meat without using a fork and a knife. And if you use a fork and a knife, you can cut this piece of meat into small bits and small pieces. And remember that the fork here in this picture is your vacuum. This is the most important, and I hear stress, the most important tool that you are using inside with your phaco machine is the vacuum, because the vacuum gives you very strong grip during the surgery, and this will allow you to get a very strong holdability on the lens and allows you to use your chopper with safety in order to chop the lens into smaller pieces. If you look at this video, you will see I'm commencing the chopping in the upper part. You do not start in the middle. You start a little bit away from the middle, and then you go through the lens, and then you start your chopping. Okay, my phaco tip here is my vacuum. My fork. I need a very strong vacuum, and I recommend I use a 500 millimeter vacuum in order to have a very strong holdability, and I don't want to allow the lens to slip free from my grip. This is quite a dense piece of nucleus, and when I use my chopping instrument, I make sure when I'm chopping the nucleus that I see the lens breaks completely, because one disadvantage of chopping is that you don't have space in the center to allow these pieces, after they are being chopped, to move in the center and then emulsify them easily. So it's a little bit more difficult, but once you acquire the skill in order to perform chopping technique, it will be, as I said before, a much faster surgery and also a much efficient surgery as well. I like about chopping actually is that I can divide the tips into as many number of bits and pieces as much as I desire. I can chop into 4 pieces, I can chop into 8 pieces, I can chop into whatever number. The more the dense the nucleus, the more the number of chops that you would like to break into smaller pieces in order to eat them easily and quickly. And this is another and last video where I'm showing again. Again, I'm showing here, I'm going through the upper 1/3 of the nucleus, and then I extend with my phaco into the center. This is a very dense nucleus, and I'm trying here to help my chopping in order to make a small trench in the center. Okay, this is like stop and chop. So I make a small trench in order to, because this is a very dense nucleus, and then I will start the chopping. You can combine, of course, both techniques, like Dr. Ala told us, a modification of a quick chop and stop and chop. You can combine both techniques in order to diminish the size of the nuclear segments and fragments in order to be able to free them, as we see here. You have, in order to be able to emulsify this small segment that you have cut off, you have to move it freely in order to be able to completely remove and emulsify it. Once you emulsified one quadrant at least, it is much easier because you have already created space. This space allows other segments to be easily moved into this free space and then emulsified with your phaco tip. I think the most important and difficult part is the first part that you remove and emulsify, because this will give you some space in order to move around, in order to move the fragments that you have already chopped, and then allow them to be emulsified, and helps in the flowability of these pieces and aid with the flow afterwards in order to remove and completely emulsify these smaller bits and fragments. And you can change, of course, like Dr. Safwan lighted up, you can change the illumination of the microscope in order to give you better illumination, sometimes according to how much you need the red reflex in order to aid you in identifying different steps in your search. And I thank you very much.
Thank you very much, Dr. Sharif. Very short and on the time and very nice and comprehensive. Excellent presentation. I don't know, but you didn't. Sorry?
I need to thank Dr. Sharif.
Okay, after I finish, you can do whatever you want.
Sorry, I didn't hear.
I need to thank Dr. Sharif for your presentation because you're shortening the time.
Thank you,
Dr. Sharif, there is also, you didn't, I was waiting to see a different way, I mean, a vertical, horizontal to show all this one. But anyway, maybe we can do also in the future. Now we will start by question by Dr. Osama Al-Jalidi. If there is any comment or question, Dr. Osama.
Yeah, to Dr. Sharif, I think that's very nice video demonstration. I think it's a stop and shop, but give you advantage of both sides, give you more space and better for than just straight shop, in my opinion.
You are correct, of course, you are right. But still, it gives you more phaco energy and more time if you do stop and chop. But if you do quick chop, sometimes, as I showed in the second video, I needed to do a small trench in order to so definitely it helps in difficult cases and hard cataracts. I agree with you, Dr. Osama.
Okay, any question, Dr. Khalid? Dr. Khalid, or comment?
I think it was really nicely presented, the phaco chop. I usually do stop and chop technique or phaco chop in some cases. And I think with time, the surgeon will develop his own way of, I mean, to move from stop and chop or phaco chop according to the case and the density of the cataract and so on. But Dr. Sharif really nicely illustrated the technique, and this is most of the, I mean, phaco surgeons and high volume phaco surgeons most of the cases. Thank you so much.
Thank you, Dr. Quraishi, Muhammad Quraishi. If there is any comment, please.
Very nice presentation. Just I have to add for the audience another technique that has been mentioned in the literature. It is, maybe it works for some people to have idea about that. It is called the rotary chop by Dr. Ifantidis. If someone wants to look at that, that makes easy for very hard nuclei. They do technique. Just I mentioned the technique for the attendings. If someone wants to have more idea about that, can look at the literature. There is this technique is working very, very hard nuclei.
Thank you very much, Doctor. Any comment, Dr. Safwan? Yes.
I think that Dr. Muhammad Quraishi mentioned that, or he mean that the trench in the center, and it will be round in the center, and then the chopping will be circular 360.
That one, another one. That one.
Quraishi.
I think a trench is made in the mid periphery from the.
Yes, that's what. Yeah, it is. I think that Dr. Yahya, he mentioned a few things related to it.
But this one, Dr. Safwan, I think it is only for soft cataract. Only for soft cataract.
I agree with Dr. Muhammad. It's for soft cataracts, not
only for soft cataract. That one is, I think Quraishi.
But he's mentioning for the hard cataract, Muhammad.
No, he is different. That means I think is different. What he is saying is different. If he is thinking about the rotational one, it is
the rotational one. So for soft
yes.
one.
Yeah, soft.
No, but he mentioned that for the hard cataract. So I'm asking.
You know, the phone that you dial that, you take the trench with the sub chopper and you drop it.
Yeah, that's for the soft cataract.
No, this is different. This is called rotary. You can.
Yeah.
Okay, let us check about, maybe also in future we can check, or on the internet we can look for that one. So I have Dr. Ala. I think we need to hear Dr. Ala to have any comment.
My comment is the sum of what have been done, that you have to learn more than one technique. One technique is not enough. As have been mentioned, start for the beginners by divide and conquer. Actually, it's very safe. And then go to stop and chop, like Dr. Khalid, for example. I believe stop and chop is a very reproducible technique that can be done in most of the cases. But actually, some cases are done by different techniques, and you have to see videos and you have to learn from your experience, actually.
Thank you very much, Dr. Ala. Yes, Dr. Sharif.
Can I ask all of the panel, please, and Dr. Muhammad, Dr. Ala, Dr. Safwan, Dr. Khalid, to tell the beginners, or when they are teaching the new residents, do you recommend for them to start divide and conquer first, or can they start chopping immediately?
For
for Dr. Ala.
For myself, I am recommending, of course, divide and conquer. Divide and conquer is forgiving. Divide and conquer is easy. Divide and conquer is reproducible. And thereafter, they can change to other techniques. But to start with, divide and conquer is a very nice technique, actually.
I agree.
I agree also. Divide and conquer is for the beginner is more safe.
Yes.
Okay, thank you. Thank you very much. I think now we can move to the last topics today. It will be by my dear friend, Dr. Safwan, consultant ophthalmologist, phaco and refractive surgeon. He's an owner and medical director of New Vision Eye Center in Dubai. Please, Dr. Safwan. He's going to talk about lens implantation. Okay.
Yeah, good evening, everyone, and assalamu alaikum. And I'd like to thank Dr. Muhammad to give me this opportunity with all these eminent speakers. So our professors, they finished everything for me, and I reached to the end. The bag is cleared, incisions done, and the Capsular Axis is done, and Dr. Yahya finished everything, and then the chopping or whatever technique that they used to remove the nucleus, and they finished the story, and they left the bag with the lens material and with the capsule, with the rexes in the center, and we need to finish the story. We have our tool to finish, the IA. I think that all of us remember the Simco that we start with when we were doing extracapsular cataract, but I didn't put it here. So IA, it's a two-way to start with, either bimanual, and that bimanual means that the irrigation in one side and the aspiration in the other, or coaxial, both of them in one side. I think that all of us, we start with the coaxial, which is the similar to the Simco, and then we divide because bimanual is more easy. Now, in certain side of the world, they are still using the coaxial in North America and state. They are still using coaxial, and the coaxial having different tips, plastic tips, polisher tips, same issues for the IA separate. Now, I need here to concentrate on what Dr. Yahya mentioned. The incision site here is very important. The angulation and the distance between the paracentesis to the main incision is very important to give the surgeon a good ability to angulate the IA in a way that he can reach all the angulation, especially for the beginners, because we need to reach the 6 o'clock and the 12 o'clock and to the other side, and we can change in a way that we can reach all the angulation and remove and polishing. The aim definitely is to polishing the posterior capsule and as much as we can to the equator and the anterior capsule. Whether someone will arguing with me whether we need to polish the anterior capsule or we don't need, this is a controversy till now, and related to the type of the lens that we will do. For me personally, I'm polishing the anterior capsule, whether by the IA or by the polisher. So that's what we are dealing with the bimanual. Second issues is that the lenses. So I will give, sorry, that's the angulation that I was mentioning. The face of the aspiration site, it should be when we are polishing the anterior capsule, its face behind the anterior capsule. And some surgeons, they are using special aspiration for the lens matter under the main incision. And for me, I'm just doing the paracentesis a little bit away from the main incision in a way that I can reach the lens matter under the main incision, but I'm putting the sub-incisional position aspiration cannula. That we can use it, or we can adjust the paracentesis in a way that it will be reaching the sub-incision matter. But when we are dealing with the posterior capsule, here there's a few tricks to remove the lens matter that touch the posterior capsule. Definitely we will see the nomogram, how I'm doing the nomogram in a way that I can tract the posterior capsule and in capturing it into the aspiration and try to remove that lens matter that adherent to the posterior capsule without rupturing it, or I can use the polisher that with the irrigation and by polisher I can remove them safely. For the beginner, they need to use the polisher so they can remove these adherent lens matter on the posterior capsule. Definitely the face of it should be toward the posterior capsule in a way that we can remove it. But for the beginner, they need a very careful way for the aspiration, because it might incarcerate the posterior capsule, incarcerate into the mouth of the aspirator, and we will rupturing the posterior capsule. Now, the second tools is the types of the lens and the material of it, and the types of the injectors that we will use to inject these lenses inside the eye and the tip size of these injectors. Now, I will go through quickly for the types of the lenses that we have. For any surgeons that he will start doing the phaco, you need to know that we have hydrophilic, acrylic, and hydrophobic acrylic. Now, that's quickly, and the type of the intraocular lenses, we have the monofocal lens, multifocal, trifocal, and accommodative lens. And those all there, these are the monofocal. I don't have any financial disclosure with any product here presented. So we can see the yellow with the UV light absorber, and the non-yellow even with the UV light absorber. And the haptics, we can see the 4 eyelets, the C-loop, the 2-piece, the 1-piece, the 4 eyelets with hydrophilic, and all these types we will be in need to use it. In the bag, I prefer the 1-piece hydrophobic, that's personally I'm using it, or hydrophilic, but in the sulcus, I prefer the 3-piece. With the whether the haptics is a plastic the plastic one means that the nylon one or PMMA one. Now, the multifocal or trifocal, and these are the many types of trifocal one. And the toric, that's correct, the toricity for the patient that they have corneal astigmatism. And the accommodative lens implantation, where we have now many types of it, the isopure for the intermediate, the lucids for +3 for the near and intermediate, and vivity for intermediate. That I don't have any financial enclosure with any of them. These are the types of the injectors. Now, if we can see, we have main 2 types of injectors. That for the preload, but the loaded now, most of the lenses, they have the loading lens. So the surgeon, he will open the box and he will have the lens inside the injector and he can use it. But for those that they have, still we are using the preloading injectors, we have 2 main types. The Monarch with the tips that we are injecting in, and I think that it's on the right side, and the right side up we can see how we are loading by injecting the OVD first, and then pressing the lens. For me personally, I'm pressing the first loop, the leading loop, to be folded over the lens, and then folding the tailor loop to be over the lens, and the lens will be sucked the cartilage, and the cartilage then put it on the Monarch injector. Now, the second type, the cartilage is being inside the injector, and that's on the left side. On the left side, we can see that the cartilage is within the injector, and we are putting the lens inside and make sure that all the haptics is within, and then folding the the holder of the cartilage, and then inject. On the left lower, the forceps that we are using to load the lens inside the cartilage for the right side. And in the middle, we can see that in the lower picture, the tips of the cartilage and the sizes from D and C and B. Now, B was the largest, C, the other one, B is 3.2, C is 2.8, and D is 2.2. Now, what we are commonly using now is 2.2. Personally, I'm using the 2.2. Hopefully that I summarize these injectors. Now we will go to the movie here. Now here is the phaco-tip in my right hand, and the left hand, I'm reforming the AC with cohesive, and then removing the phaco-tip, and the movie will start. Here I'm filling and then removing. Now the first step, sorry, it was methyl to remove the lens matter, and I'm removing the lens matter here, going to the angles. See, I have the ability to go through. Sorry, the movie is very quick. And then we can see that I changed, but before changing my hand, I'm refilling the AC with. And see, I can reach under the main incision clearly, and can see that the tip, the face of the aspirator on the anterior posterior capsule, easily to remove all the lens matter using the three light dots here, and then cohesive to refill the bag and the AC. Refilling again, and then I'm using, see, I'm using the, just remove it. I'm just here injecting the lens inside. This is the four eyelets. Rotating the lens to the side. Then IA to remove all the methyl. That's cohesive, sorry, remove all the cohesive from the AC. And from the behind of the lens. Rotating the lens. I have the habit to rotate the lens. If there is any lens matter and the angulation will appear, I'm putting triamcinolone in the AC just to make sure that I don't have any remnant of the OVD in the AC. Sometimes we cannot see it clearly, and then here I'm finishing, clearing all the OVD from the back. Stromal hydration, 2 dots to see the reflex, red reflex, and then finished. Thank you. Great, thanks for all. Dr. Muhammad.
Thank you very much, Dr. Safwan, my dear friend. Really an excellent presentation as usual. And this time also on time. You are very nice. Thank you. I think we already come to the last. So if there is any question to Dr. Safwan or comment, I will start this time from Dr. Ala. So, because actually, you are a friend of Dr. Safwan, I want you to...
Yes, of course. He's a dear friend. Thank you very much, Dr. Safwan, for the very nice presentation. Actually, we can discuss a lot of topics about the IOLs, but I will go through, you have mentioned accommodating IOLs in the lucidus plus 3 diopters. Up to my knowledge, there is no accommodating IOLs up to now that has proved itself in the whole world. And what is available now is the diffractive and the EDOF we have the trifocal or the diffractive technology and the EDOF technology. Actually, the accommodating IOL, although they are the first to be FDA approved since more than 15 years, but actually they didn't prove themselves and they are vanishing now. What's your opinion about accommodating IOLs?
Dr. Ala, what I mean is the EDOF. Maybe by mistake they put
because they are not accommodating. Accommodating is like.
I apologize for the title. Okay. It was the different title. It's what I mean is that the EDOF.
Okay, Dr. Muhammad Quraishi, if there is any comment or question to Dr. Safwan.
No, thank you very much. Very nice presentation. I just wanted to mention that there are two techniques for IOL injection. One is wound assisted and the other one is going inside the wound. Usually at this time, most people do wound assisted because we need smaller incisions. So with
it is 2.2. That's why it's intra wound. This is the inside the incision.
Okay, that's called wound assisted.
Wound assisted.
Yeah,
it is. That's why I mentioned that the two type of the cartridge that I'm using, the cartridge built in the injector and the cartridge that I'm using on Monarch is 2.2. So I'm using the assistant by the wound assistant.
Right. But if you have a 3-piece lens, you have to go inside the wound.
Yeah, that depends, because I said that the 3-piece, I'm not using it regularly. I'm using 3-piece when I have a rupture of the posterior capsule, in a way that I can put it in the sulcus and with the capsular capture. And here I'm using the D, which C, which is the 2.8. So here I'm enlarging the incision.
And with the Alcon Monarch, you mentioned that it is preloaded. I think it's not preloaded. It's called preloaded. It is not.
No, it's not preloaded. It's loading. But I said that now we have a preloading on the same way of the Monarch.
Okay. Thank you very much.
Now we have a machinery. Now preloading and the machine. There is now automatically loading, means that you are pressing on a foot pedal and then it's a press. But I don't need to mention it here. It's not because this is for a beginner, and for the beginner we need to teach them how we are using the classical way.
Any comment? Yes, any comment from Dr. Khalid? Dr. Khalid, please.
Thank you so much, Dr. Thank you so much, Dr. Safwan, for your nice tips. You have touched up a lot of things in phacoemulsification. And my first comment was the comment of Dr. Ala.
No, it's only mistake. The title was mistake. It's EDOF.
For the audience, for extended depth of focus, the EDOF. This is, I mean, we have used these IOLs, and I think these IOLs are good sometimes to replace the monofocal lenses, not to replace the trifocal technology. Still, the trifocal is the way to go when it is suitable to give the patient the ability to read, or even to see the far, or even in the intermediate for the suitable cases, not all of the cases. For the EDOF or extended the focus, I have used Lucidus itself. I have good experience with it. And it doesn't give a lot of good reading ability, actually. It gives an intermediate or even far with the less extent of halos and glare could be noticed with the trifocal lenses we have seen. And we have a lot of...
Khalid, it's a big subject. I just for the titling.
Very important, just to tell you, I mean, ask you about the Kinocort. If you want to use it for the regularly, I mean, it is important not to use it whenever I mean, you have a vitreous or you have really difficulty to visualize the things, not to OVD. OVD could be removed even without the use of Kinocort or something like that, because of, you know, the Kinocort injection in the AC could increase the risk of glaucoma or other risks.
Well, Khalid, if you are asking me personally that whether I have any patient with a glaucoma post, it's not. Actually, using my lenses is a premium. So patients, they are irritating after the second day with any OVD in the AC, and I'm using cohesive. Cohesive in the AC can create a lot of reaction. So with when I'm suspected any vitreous loss, in that case,
Yes.
there was a suspicion of suspect.
Yes.
So I put it a lot. I use it a lot. Otherwise, I'm using it just to show the AC is there is any.
I agree.
So it will be very, very tiny in the AC. But here, when we have, because if you look at the movie at the end, I rotate the lens 360, thinking that if there is anything behind the lens. So that's why I use the triamcinolone in an extensive way.
Yes, can I have a comment, Dr. Muhammad,
Yes,
for
yes,
the
please,
beginners?
Dr. Ala. Yes.
Just the difference between cohesive and dispersive in removing the viscoelastic. Cohesive viscoelastic is removed so easily. It gets out as a bolus, and it's very difficult to leave part of it inside the anterior chamber. That's why Dr. Safwan is not getting any cases in his practice. Actually, the problem is the dispersive. The dispersive, you cannot get it fully, and 100% you are leaving some parts of it inside the anterior chamber. And that's why everyone who is beginning phaco must know the difference between dispersive and cohesive, and when to use that and when to use that. When removing the cohesive is very easy to remove, it gets out as a bolus. The dispersive is much more difficult to remove, and 100% there is some pieces that remains, and that's why there is post-operative spikes that may happen during the first 24 hours.
Thank you very much, Dr. Ala. Yes, Dr. Osama?
Yeah, just thank you very much. It says, as Dr. Safwan demonstrated, really bimanual aspiration is very handy, very useful.
Yes.
Better than coaxial for all cases. I think I recommend bimanual all the time. And also viscoelastic, once you inject the lens, I think it's better to wash the viscoelastic behind the lens first before you do the washing in the front of the lens.
Well, sometimes you cannot see the behind of the lens if you didn't remove the above of the lens. So if you will start with the back of the lens without clearing the anterior, the above of the lens, you cannot be sure that you are safe and you can remove it. As Dr. Ala said, it's a cohesive, so it's very easy coming. That's right. But you need to be sure that you will not aspirate the capsule with it, because sometimes the amount of it's under the lens is very low. So when you are removing it, you are having a risk of the capsule. So I'm clearing the AC first and then going behind the lens.
Thank you very much. I think if you want to go more, it will take more and more time, and it's a very interesting subject, and we need more times also for each points to discuss. Maybe in future we can give for each point more times for discussion.
Dr. Muhammad, I recommend please to do some session for types of IOLs. Actually, a lot of discussion can be done according to which type of IOL. For example, Dr. Safwan has mentioned yellow IOLs. Who of you are still using yellow IOLs, and what's your recommendations? This is a question open for all the participants. And what's the advantage and disadvantage of these yellow IOLs?
I think Dr. Ala, we will do a refractive sessions, and we will keep this part of it maybe, or as in the end of this series, we can keep one day for this one for controversies and IOLs. Yeah. At the end, I would like to thank you all for this very interesting, and I'm very happy that I have this kind of eminent speaker talking, and we are having many attendees. They are still with us till even we go more than half an hour, more than what we are planning. Thank you very much, Dr. Ala. Thank you, Dr. Safwan. Thank you, Dr. Muhammad, Dr. Osama, Dr. Sharif, Dr. Khalid, and Dr. Yahya. And also thanks for Dr. Loka for being with us. And we hope to see you, inshallah, on 23rd of, on 16. We will have another session of 16. It will be Ramadan, and we'll try to make it by 10 o'clock UAE time to start. Thank you very much, and good night. Thanks a lot.
Thank you. Thank you.
Thank you.
Good night.
Good night.
Bye. Good night. Bye-bye.
Bye.
Good night.